Hello, today we will be reviewing two endoscopic discectomies performed by Dr. Albert Telfeian. First case is a transfemoral approach to a right L5-S1 disc herniation. Patient is awake under conscious sedation for this procedure. Here we have the preoperative MRI showing the herniation. Next we'll look at the approach at the time of surgery using a needle to target the corner of the end plate of S1 laterally and the medial wall of the pedicle on AP view. When we have the approach planned, we advance an 18-gauge spinal needle with a K-wire, continue to take images to confirm location. Scalpel is then used to create a small incision over the needle. With the K-wire in place, a series of dilators are inserted, followed by a series of sequential reamer drills. This is used to remove the ventral portion of the SAP. Next, we insert the beveled tubular retractor over the dilators to confirm placement with AP and lateral radiograph. At this point, we are able to insert the working channel endoscope and begin removing the disc herniation. The initial view upon insertion endoscope often looks similar to this image, and cautery may be necessary to control any bleeding and enhance the view. We then perform the discectomy using a series of instruments, including the graspers seen in this video. We utilize several different instruments to assist with the discectomy. Some of the graspers seen are more aggressive than others, and others are angled and flexible. We also utilized a blunted ball probe to dislodge any loose pieces. Here you see a disc fragment being removed. This fragment measured about 4 millimeters, and the patient was able to voice near instant improvement of their preoperative symptoms. Moving on to case number 2, we have another endoscopic discectomy, this time level of L1-2 above effusion. We begin with our pre-op images, which are shown here. You will notice the large herniation in relation to the existing hardware from the prior procedures. Again, similar to the prior case, using a spinal needle to assist with the approach, targeting the SAP and then sliding ventrally. We can advance the needle until it lands on the superior corner of the L2 vertebrae. Next, we can confirm our placement with an AP radiograph. This should show the needle medial to the medial wall of the L2, inferior level of this surgery. We can now begin utilizing the dilators to access the levels of L1-2 by stretching the muscles. We can insert the same reamer drill as the prior case to shave a small portion of bone. When the reamer drills have done their job, we can tap in the beveled tubular retractor, take an additional AP and lateral radiograph to confirm our location. Please take note that the retractor is in the foramen and not intradiscal. In this view, you can actually see one of our endoscopic graspers open and removing a disc fragment. Now we are going to be moving to the endoscopic camera view to see how we cleared out this herniation. In this video, you can appreciate the work that is being done with the blunted ball probe. For this procedure, the ball probe proved to be a very valuable addition to the toolkit. We're able to dislodge herniated disc fragments, creating an easier opportunity to remove these pieces using our various graspers, which you saw in the first video. For a large portion of this procedure, we utilized a combination of the ball probe with the irrigation to help the fragments flow out from the existing port which we placed. You can see that throughout this video, and it does a good job of showcasing that you do not need to always rely on your graspers and can get a good discectomy performed by utilizing all the tools available to you. Here we are following a large disc fragment as it is irrigated out of the beveled cannula. You can see some of the larger pieces being pulled away, utilizing the endoscopic graspers here. We resume utilizing the ball probe to attempt to dislodge any remaining loose pieces before we complete the procedure. This patient remained awake during the procedure. They were able to communicate with our team throughout. By conclusion of this procedure, patient was able to report a near full resolution of preoperative symptoms.